Hi, Dr. Rodarte. How are you?
I am good. Good to see you as well.
I haven't seen you probably in about a year, I guess, is probably the last time you came to Texas.
Yeah, last December, I think it was.
Yeah, well, almost a year. Time flies. Well, I love that you're on. I've just been so impressed with you. Number one, just meeting you and seeing everything you're doing in your clinic, in your community, and just your approach is so refreshing. But I know there's probably got to be a story there that you didn't really start out coming out of, school and hanging your shingle and doing, what you do now probably didn't happen overnight. So share a little bit about yourself, your journey, your medical journey, and, where you were, where you are, just to give everybody kind of a feel for how you got here.
Yeah, that's a great question. And first off, thank you for having me on. I love our discussions, and so it's an honor to be on. Well, I always wanted to be a physician. That was something that I remember back at 5 years old, starting to talk about it, loving my doctor kit and wanting to just do it. And I was blessed. I'm first generation born here in the United States. My parents immigrated from Lebanon. And so I understood kind of the medicine from not just taking a medicine. I thought that was great. My mom had the Mediterranean diet initially, and I actually, my kids in school thought I was actually getting poisoned because I did bring the typical sandwich to school.
I didn't have a package to rip open that had bright colored foods in it.
No, they thought I was eating grass, because they thought tabbouleh, and they're like, what is this, eating grass, so I understood.
I love tabbouleh.
Yeah, I understood the importance of nutrition very young and how it could help with avoiding illness or helping you get better, or keeping you well. And so as I moved into my older years, I got to shadow a DO and loved how she incorporated Eastern and Western medicine. Like, she held her patients' hands, she prayed with them. She wanted to know how their family life was, how their job was. She really felt that was important to how they were going to take care of their health, how they were going to age. And so I did. I sought out becoming a DO, and I did do an allopathic residency, an MD residency, and that was because I decided to have kids coming out of medical school. And it was the top-rated internal medicine practice in Arizona at the time, and I feel blessed to do that. So I really got to learn integrating Eastern and Western medicine. I will tell you, I had to seek out the more certifications after residency. I think a great takeaway for those in medicine is keep learning. And that's what I did. I went on and did hyperbaric medicine, wound care, which really taught me how to help the body heal. And then really got into functional and internal medicine. And I should back up, obesity medicine is really big. Because if I could help my patients lose weight, then it took care of their diabetes, their high blood pressure, their high cholesterol. They were moving. So it was really important for me to help them lose weight safely. I started my journey for that in 2008. So
wow, before it was even a thing, I guess, like it is now. That's so awesome. I love what you say about doctor of osteopathic medicine, because my first, when I was a medical assistant, my first job was for 2 DOs, and they did adjustments. They focused on food. They focused on breathing. They focused on the spiritual aspect, but just as much allopathic, medicine combined. And that was my first introduction into that. And, the one doctor that I worked for, he was the president of TCOM, in Fort Worth, which was the Texas College of Osteopathic Medicine at the time. It's something different now. But everybody he was ahead of his time. This was back in, 30 years ago. Whoa,
yeah.
I can't believe that long. 25 years ago. And, people kind of just thought he was crazy and he was a quack and, all this Ayurvedic, and he was having you put special spices on your popcorn and things like that. And, but he was ahead of his time, really. And that always stuck with me, He would take time and spend time with his patients teaching them how to chew, what doctor is teaching you how to chew your
Yeah.
and it was my first exposure to any medical provider that was talking about supplements, and they actually had supplements in their office that they sold, which was so different. So I love that background, and that DO influence is just so key. So you talk about this activated health and wellness. So what does that mean to you, this activating somebody's health, and how does that differ from kind of more traditional approach to medicine?
Yeah. I believe our bodies are wired to be healthy. And I would say the term activation is so new because it seems like we only know about supplementation and replacing or just treating. And activation is actually activating the cell to return back to normalcy. And so that's why I decided to really name my practice Activated Health and Wellness and talk about it, because I like to tell my patients, like, our cells want to be healthy. And there are pathways now that we know about that can activate health. And so it's a key. And I think if people think about it, then they're more inclined to move towards it too, thinking, oh my gosh, I'm not just stuck with this. I can help my genetic expression. I'm not stuck with whatever grandma and grandpa have, I'm not going to ultimately have. And so that becomes really big discussion with my patients is you can teach a dog new tricks, our brain, like neuroplasticity, all of these things. So that's why I chose the term activation and activated, because I'm hoping that it triggers in them going, I can have control over this. Yeah,
absolutely. What a great term too, because it kind of gives you the vision that this is something that is proactive and not reactive, right? It's not a passive approach to your health. And that's a big thing about right now that we're really focused on, and you are as well, is teaching and giving people the tools to be in control of their health again. For too long, we've been passive consumers of, I don't even want to say healthcare, it's more sick care. And I think people are starting to kind of really want to move away from that. So that's just I love that activated health. I mean, I hadn't really even ever thought of that before, but that's really brilliant, actually. So this personalization is a huge part of your activated health and kind of personalizing the approach with your patients. What does that mean to you, and what does personalized medicine mean to you? I know you focus on a lot of obesity medicine. Obviously, we'll talk about that in a minute. But when it just comes to long-term health and wellness, what is this personalization, and why is it something that's so important that we're missing, that we really need to be talking about more?
You talked about even what it looked like. I think we're roughly the same age. If you think about what it looked like 30 years ago, we were talking about what their lifestyle was and how their nutrition was and everything. And we got away from that. When I got into practice, around 2005, it was very cookie cutter and I didn't like it. And like, if you have this, you get this.
Yeah.
Or if you have high cholesterol.
Recipe that we followed.
Yeah. And it just didn't sit well with me. And so thank God I just wanted to keep learning it and figuring things out. This was about the same time, I won't jump around, but I was taught about hormones, and then hormones were voodoo. And then I was like, oh my gosh, but I have to help my patients. And so I just continued to keep an open mind. And I realized that the more I tailored the treatment protocols towards my patient, I learned about their lifestyle, the more success I would have with them. And so it flourished from there, knowing that it needs to be personalized. Yes, I have a tool belt with everything I've learned, and I'm going to wait till they're in front of me and they start talking to me and we have a discussion to see, one, what are they more likely to do? Because if someone told me to go run a mile right now, I'm not going to do it. I've always hated running, but thank God someone said, hey, why don't you try yoga or Pilates or boot camp? So we have these tools, and they work best when we say, hey, which ones do you want to start first? And we also say that personalization is like, you know what, your A1C is 11. Let's start with a couple medications right now. and lifestyle changes. And as we start to see it come down and down, it doesn't mean that you're always going to have to be on these medications. So I really feel like tailoring it, listening to the patient is so key, and knowing that it's not one size fits all. Because what I think in medicine, what a lot of providers are upset about or they get flustered with is they've only learned to follow a track. And when somebody doesn't respond, they're like, it's got to be the patient's fault. Well, how about we think about it's really not. It's not one size fits all. So I love the personalization aspect.
No, that's great. And for clinicians that are listening, that might be listening, it's so important to understand that, because I think we have gotten used to, like I remember when I was in school and learning all these different protocols. Well, we had, up to date where you just typed in a disease and it gave you the recipe of what to follow for that disease. Probably, one of the few things were lifestyle changes, but we skimmed over that and went right to the prescription, right? I mean, because, and I remember even learning that, lifestyle changes are always the first thing you do, but anymore, to your point, we just kind of gloss over that. Or as a clinician, I've heard many clinicians say this is like, I don't even do that because they're not going to do it. So we just go right to the prescription. Well, you're setting your patient up to fail out of the gate because you've got a preconceived idea of what they might or might not do. And that's the difference between a personalized approach is really sitting, because, you said it earlier. If I sat down with a clinician and they told me out of the gate, I needed to stop drinking coffee, stop drinking wine, stop, I would say, you know what, forget it. I'm just going to stay like I am because this is too hard. So you got to meet people where they're at, right? I tell a story a lot about a patient I had came in that she was having chronic headaches all the time, chronic migraines. And, we fixed her hormones and all those things. I kind of usually start with what's the most obvious thing. She was very hormone deplete, but her headaches just weren't going away. I was like, let's, in her follow-up visit, I said, all right, walk me through your normal day of what you put in your body. I mean, from thoughts to drinking to food. And we peeled back that she drank on average 3 to 4 big gulps of Dr. Pepper a day. And I was like, I really think that that's your problem, but it's very addictive, right? Yeah. So rather than telling her, you have to stop drinking Dr. Pepper, we met in the middle and I said, can you bring those 3 big gulps down to 2? Yeah. Let's just start there. And you just have to kind of meet people where they're at. And I think that's what you're talking about with your personalized approach.
It really is. And I have stories like that. I sometimes I had someone doing 3 or 4 liters of soda. And I was just like, how do you have time to do all that?
Exactly.
Yeah. Because they will, that when you say, I need you to stop soda, they're going to be like, oh no. But
check, please. Thanks. Yeah, no, you gotta meet people where they're at. So, can you kind of give us a little bit of an example of how a personalized approach to your patients might differ from, just even for people with similar health goals, but how you get there? We need to get across the street, but do we go this way or do we go that way or do we go this way or do we go direct? What are some different things that you like to,
Yeah, so that
is,
I think sitting down, I have almost a 6-page questionnaire that my patients have to do first, initially sit down with me the first time. And that gives me a little bit of a roadmap. And what I tell them too is there's only so many questions I can ask on this. So at any point, I want you to interrupt me and say, hey, doc, I think I need to tell you about this because now, this thought or this experience would triggered by us talking. So I like to see that. You talked about, a roadmap, walk me through your day. I sometimes walk me through your day or walk me through the last 5 years or, you said this all happened when you were in high school. What else was going on? So I like to kind of build a rough draft of what's going on. I do a basic lab panel for everyone who comes in. And it's not your typical just, are you anemic? Is your liver and kidney fine? Is your TSH fine? And that's it. I a lot of my patients, I'm like, hydrate really well. We're at least taking 6 vials, not 4. And then as I sit and I talk with them, I decide if more is needed. if they need stool analysis, if they need, there's a lot of things now that I do, I've dipped my toes in functional medicine. There are more testing that we can do at times, but I don't start there because there's a lot of that we can kind of get to before that. But I would say because my average age is between the 35 and 65, a lot of hormonal things are starting to happen. So we talk about that. I do include hormones in their panel. And we go through. That's kind of how I started off, because then I'm building my treatment plan. I'm also seeing how willing they are to change. Are they like, throw everything at me, I will do it all? Or are they
favorite?
Yep. Are they like squinting, going, oh my gosh, she's going to have to pry each and everything out of me, And so then I'll even tell them, okay, we're going to see each other maybe weekly at first, or we're going to see each other monthly, because I need to know how much hand holding am I doing? How much changing am I doing? Depending on if they come in on 12 medications, I can't stop them already right away. But I want to be on top of things where we can adjust as they're getting healthier and healthier. So, it's a lifestyle change ultimately.
Right. You said something earlier that I want to kind of circle back to, because this really just struck me. And when you first started talking about this activated approach, instead of just looking for, because this just stuck with me, how we're kind of chasing even supplements to fix a problem. It's kind of no different than chasing a bunch of medications. It's just a different type of medicine. I love supplements. Obviously, we do a lot of them, but what you talked about with activating your cell's natural ability to heal, talk a little bit more about that, because I love that thought process. And sometimes we do need certain nutrients and nutraceuticals to help that along. But rather than throwing a bunch of, darts at a dartboard and seeing what sticks, how do you start this conversation with patients about activating your own body's innate ability to heal itself?
Yeah, so I started off by looking if they have any nutritional deficiencies, because how can those cellular pathways work if they have nutritional deficiencies? So we might supplement them initially to kind of help activate their cell. But there are also activators out there. Like there are things that help mitochondrial biogenesis. There are NRF2 activators. It's a pathway that's very good at leading towards reducing oxidative stress. There are peptides that are being used. So it becomes personalized. I'm not going to tell everybody that you need a B vitamin. Not everybody needs to be on Smorelin. Not everybody, so it becomes personalized depending on where they're at in their health journey and what key processes or pathways do we need to activate. Is this someone who has had mono, and they have chronic mono? Is it that's Hashimoto's, and no one has ever told them that their diet, like being on a gluten-free diet, could actually be beneficial to helping their thyroid? Where is it someone who has survived cancer and they had an oncologist that just wanted them to eat because they were losing weight, instead of saying it does matter what you are nutritionally putting in your body? So, and I think this also stems from when I did wound care. Like we were actually really key onto how our patients ate. And then we would do like high dose vitamin C's. We'd throw them in the hyperbaric oxygen chamber. And so it really, really was a big learning point for me to go, this is bigger than I even knew, it was.
Yeah.
So,
yeah. And just taking for granted, vitamin C and protein and all the different things that, wounds need to heal. No, I love that concept. And, we talk a lot about mitochondrial health and different shows. Dr. Laval and I talk a lot about mitochondrial health. And that's really what you're talking about. Mitochondrial function and really trying to help the body do what it already knows how to do in repair and recover. That's so key. And bringing those concepts into what you're double board certified in internal medicine and obesity medicine. Let's talk about obesity medicine. I think the term kind of speaks for itself, but maybe not. Maybe we have a preconceived idea about what obesity medicine means. Tell us a little bit about that. And then how do you bring this concept of personalized, activated approach, activating your body's innate ability to be well in that area of medicine? That's probably challenging, but you're clearly very successful at it.
Yeah, the weight loss field has changed so much. And so I wish it was called something different than obesity, because obesity does have a negative connotation, unfortunately, where we want to say someone has obesity other than they are obese. So the terms can be hurtful for some people, and I totally understand that. But I'm very thankful that there was a board certification that I can do, because I learned it was definitely more than just reducing, your caloric intake and calories out. Yeah, it's so much more than that. There are so many genetic predispositions that we know about. And so the neat part about this is there are a lot of tools. There are definitely a lot of medications that are out there. In the last 5 years, we've seen them just skyrocket. But in the last 5 years, especially the last 3 years, I think what we've seen is in the wrong hands, it can be detrimental, where we'll see sarcopenia, we'll see gastroparesis, we see the side effects of not doing it correctly. So I have been a very big advocate to be doing it with providers that have had the adequate training. Because I love to tell people I do not have patients with sarcopenia. I do not have patients, because I don't titrate up their medication so that they're not eating at all, nor I don't get their medication if they're not doing all the other things they're supposed to do as well, like exercising, and, the list can go on. But there are probably 10 to 12 different medications that most people have never even heard of to help with weight loss. It's not just injectables. So that's where the personalization comes through. And we like to ask questions. Was weight something that came on in childhood? There are different genetic markers that predispose you to weight gain from childhood, teen years. Were there some traumatic events where weight then came on as a shield? Were there medical issues? Like my last 2 patients today, PCOS, they were given Depo-Provera for years upon years, and I'm having to peel that onion back so that they can safely lose weight, because the main point of them getting on Depo is to help them out. But nobody thought about, maybe we'll just do this for over a year, didn't look for the root cause, right? So personalization in my world when it comes to obesity medicine is looking at confounding factors. When did the weight come on? What have we tried to get it off? What are the comorbidities now that you have? Are you skinny fat as well?
Mm-hmm. A lot of that.
Yeah. And so then we start to personalize it. We might not start with injectables. And I'm sure most of your listeners are like, oh my gosh, she said, don't start with an injectable, and there are a lot of medications out there, like still the oldest and my most favorite is phentermine. It's just so easy, so cheap. It's something that I might use initially because they only need 10 pounds off. Something else is going on. I might need to just get their thyroid and their hormone, their female hormones going, and then they're good to go. So phentermine was used for maybe 30 to 60 days, and I didn't have to deal with trying to get an injectable in them. So, there's such an art to weight loss medicine, obesity medicine, that I really want people who have the passion to do it, get into it instead of just looking for the quick return of an investment and looking at that patient as dollars instead of a person.
Absolutely. You hit the nail on the head too. And we've talked about this in so many different realms, and because obviously you're talking about GLP-1s and how, and they're a game changer. They're amazing. But most providers are utilizing it in the traditional allopathic way of just to lose weight and not paying attention to, well, what kind of weight are they losing? Are they losing muscle? How can we prevent this? I we don't get sarcopenia patients in our office. Why? Because we're optimizing their hormones. We're doing body composition analysis to see when you come in, what weight loss did you lose fat or did you lose muscle? Did you lose bone? I mean, these are all really important things to look at. And that is what makes it super personalized. You touched on something that I'm just so thrilled that you said it. And that is addressing the emotional wounds and the emotional aspect. Tell me a little bit about that and how you integrate that in your practice, because that's probably something people don't expect. But it's so important because when you can tie it back to a traumatic event, you can help give them the tools to heal those wounds. Man, that can be permanent.
Yeah. I, through the years, have made incredible relationships with therapists, counselors, psychiatrists, because I feel like I needed to make those connections so that my patients who already trust me will trust who I'm referring them to. And so it is something in my first questionnaire that I asked them about. And then later on, if they didn't want to disclose it at first, they didn't know if I was a safe place, as we've worked together, I might, go deeper with certain questions, or something might go on, or even on their journey, something might happen. And so I very early say, okay, I want to refer you to someone who can really go through these traumatic events or, these thought processes. And there's actually like CBT for weight loss, cognitive behavioral therapy. Hypnosis has helped some people as well, EMDR. So even now, more people understand ketamine and TMS. So I am big on referring out to that, because I know we are going to be not as successful if this isn't addressed, especially if it's someone who has yo-yo dieted. I know that they're gained and lost 50 pounds, 60 pounds, even up to 100 pounds. I'm like, there's something more here.
Emotional piece that's not been addressed.
Yeah.
That's great. And that's part of bringing in the Eastern, thought processes too. I didn't want to gloss over that you said that, because that is a key missing piece in, a lot of weight loss programs. To your point, there's a lot of clinics that all they do is prescribe phentermine prescriptions. And then there's some now that only just do GLP-1s. And this is a big wheel that has a lot of spokes. You have to address it all. And one of the things that you really do, differently than a lot of weight loss specialty, is you make sure and address the hormones. So talk a little bit about the hormonal aspect of obesity medicine, or just weight loss, because it's such a huge piece that I think so many people are missing.
It is so huge, and I love hormones. And it's another piece where I'm like, if you don't have someone that knows what they're doing, please go find somebody else that does. And so it's huge. So I will say, as I was mentioning, kind of like that age range that of a majority of my patients at 35 to 65, this is the biggest time where we're starting to see, maybe premature ovarian failure. We're seeing perimenopause, menopause, and a lot of physicians and providers don't know what to do with that when they're like, I'm starting to gain weight. Oh, it's a rite of passage. No, let's figure it out. We want to optimize our health, and we want to not be, moody and have a belly and start, having the risk factors, for dementia and bone loss. So, and it goes for our men too, So, I was talking about women, but even our men need, checking their testosterone early. And I think it's because we're seeing so much disease presenting earlier than in our parents' generation or the generation before that. And that's a whole different topic with nutrition and food and environment. But I think we need to be looking at these aspects very early in their process and saying, you know what, and they might be, let's say, borderline. We might go, okay, we're going to do lifestyle changes. Maybe we'll supplement here, we'll activate here, and then we'll recheck. Maybe you don't need to go on hormones just yet. We just needed to really help optimize your health. And then others are like, oh, we want to just confirm and help them know, no, you are not crazy. You are truly perimenopausal at 40. I'm sorry someone said you had to wait till you were 50. They're wrong. You can.
Exactly.
let's get started now. And that brought up how you were mentioning, like, I mentioned skinny fat. So many people don't know that during these transitions, they'll have a fat percent that puts them in the risk factor of insulin resistance and prediabetes, where a majority of providers might say, oh, we don't really treat that until you are a diabetic or you do have high cholesterol. And I'm like, no.
Like saying, let's not prevent cancer until you get cancer. Like, what? Yeah. It doesn't even make any sense.
So I really believe we have to optimize hormones with our patients who are losing weight as well, because a lot of times the weight gain came on because of their hormones are not imbalanced. Yeah,
absolutely. And the other thing too, I've seen this in patients that have come to our clinics from, either their PCP got into writing for GLP-1s or they went to, some sort of telemedicine GLP-1 clinic, which makes me crazy. But they come back and they've lost the weight. But when you put them on that body comp scale, their fat percentage is high. And so I think this is a common misconception. Just because you've lost the weight and you're thinner doesn't mean you're necessarily healthy, because did the times that you were you eating packaged processed foods? What were you giving your body, And so if you're doing that, your body's going to start cannibalizing itself. I mean, correct?
Yeah. Guys, you would lose your muscle because they need the amino acids from somewhere. So they're going to they're going to start breaking down your muscle because you're deciding to inject yourself and not be hungry. But then when you do want to eat something, you're like, oh, instead of a whole bag of chips, I'm eating 3 or 4 chips, but never even thought about the protein intake. But on the flip side, I know we've talked about how these injectables are being used inappropriately. When they are used appropriately, I love this class and I want to protect this class because there are several studies, even if you think about 10 years ago, talking about with the first generation that came out of them reducing inflammation and, cytokines. So the sky is the limit with them. I just really wish we could only have the providers who understand how to use it.
I love what you just said about protecting this class of medicines, because that is so important, especially the ability to compound them and get them in doses that people can tolerate. Need the big doses in many, many cases if they're not already full-blown diabetic. So so important. And so for any people that are listening that are maybe going to a clinic that's really just prescribing them that and maybe food for thought, there's more to the conversation than just getting your prescription and doing your injection every week, and really wanting to work with a clinician that understands how to do this in a healthy way, because the goal is to get them off of these medications, obviously, correct? I mean,
or using it to the least amount. That's what I love about also. Why I want to protect the compounding aspect of it is because then I'm not getting yelled at by an insurance company that says, oh, they have to, fill it every 30 days. I'm like, but when you're using a smaller amount, maybe they're injecting every 14 days or once a month, because they're in that maintenance phase and things are just controlled. So it's that ability for us as practitioners to say, we know what's best for our patient and being able to change their treatment plan according to whatever is happening in their life and how their body is functioning now. So I love the ability of microdosing and changing the dose and being in control of it to help my patient out. They are
just better.
Yeah.
100%. So just to kind of wrap it up, because I think people are always looking for, the common myths and misconceptions about obesity and overweight, or just even weight loss, that you kind of feel like you're always addressing. This is a common thing that people think that might not be true.
Yeah. Well, the first is eat less, exercise more every day. It is something I have to say, no, it isn't. That is not the whole picture, the whole eat less, exercise more. So I think that's the biggest misconception. The second is, that perimenopause is real. Yep. And you don't have to wait till you're full-blown menopause to talk about hormone replacement with your providers. Like, please find somebody that knows. It goes on both ends. Please find somebody who understands weight loss, that is obesity medicine certified. And number two, when it comes down to hormones, find someone who really does understand it, whether it's your thyroid or your other hormone, because there is a magic to this, and there really is. And finding someone who finds the passion in this instead of just hurrying up and writing a script, I think is really key. And the third is, I would say we can optimize our health no matter what has happened in your life, no matter what infections you may have had, no matter what your grandparents had. You have the ability and the control to optimize cellular health. So that's...
Yeah. And not being a victim to, I see this a lot too, not being a victim to, we focus a lot in our history of, well, your family history, do you have family history of cancer? Do you have family history of that? I mean, yeah, I guess it's kind of important to see where there might be risk, but that doesn't mean, that doesn't mean that you're going to fall on that sword, right? I mean, you don't have to. I love every aspect about what you're doing. The fact that you're, bringing in the empowerment aspect and empowering patients in this way and not being reliant on you. I think that's another big difference between more integrated type of practitioners is how we empower our patients. What I want is I want to empower my patients to be so healthy, I don't really need to see them anymore. Right? I mean, yeah, it's like you're working yourself out of a job, but that's really what our job is to keep them healthy. Any last words of wisdom or thoughts or things we didn't cover before we wrap it up?
Oh my gosh, this was amazing, just being able to talk about all of those subjects. I just pray that people are like, oh my gosh, there's more than just getting a prescription and waiting for it, waiting for a disease diagnosis and getting a prescription. Right. There's so much more than that. So no, I thank you for doing a podcast like this, getting the word out. Your book is awesome. Everybody it opens the window, and the door for others to go, like, there's so much more. Let's get in control again, instead of kind of, feeling, like a victim and you can't do anything about your health.
Yeah, absolutely. I love it. Well, thank you so much for your time. I know you had a busy clinic day, and I appreciate you tacking me on at the end of the day. And looking forward to seeing you again next time I see you and seeing what you're up to. Hey, everybody. Thanks for listening to this episode of the Dr. Terri Show. It is truly my heart's desire to help people to bring awareness to key issues affecting our health, both mentally, spiritually, physically, financially. So if today's episode was helpful to you, would you please share this podcast with others? This information is vital for helping our country heal and restore our health, and we would be honored if you would pass it along to your friends and family. Be sure to subscribe so you don't miss any content from the show. And if your life has been improved by the show, please leave us a review below. We would love to hear from you. See you next time.